Hi, I'm Piper Harris, a licensed professional counselor, and welcome to the Untangled Mind podcast. This is a show for people who want to understand why their mind works the way it does, not just how to cope with it. Drawing from neuropsychology, neurophilosophy, and data-driven CBT, we look at how anxiety and trauma shape perception, behavior, and choice, and what actually helps people change. I'm an integrative CBT therapist based in the Atlanta suburbs. Each episode is designed to teach you something concrete: how to recognize what's keeping you stuck, how to interrupt unhelpful patterns, and how to move forward with clarity and steadiness. Therapy is everywhere right now, but effective therapy is not. Last episode, we unpacked what bad therapy actually looks like, the vague, unstructured, feel-good sessions that leave people spinning their wheels. Today, we're going one layer deeper, because even when you found a therapist you like, it's shockingly common to end up comfortable, but not changing. Over the years, one question has kept surfacing in my work. Why do so many people stay in therapy for months or even years, feeling heard and supported, yet their symptoms, their relationships, and their daily life show no real improvement? That same question is what keeps driving these conversations with Dr. Emily Ferrara, founder of Simplify Life Counseling and Coaching, a practice specializing in evidence-based treatment for OCD. Our ongoing dialogue comes from shared clinical values, shared frustrations with the status quo, and willingness to say what many clinicians won't. Sometimes the therapy that feels safest is the one quietly keeping you stuck. In this episode, we're getting very specific about the 3 clearest signs you're in stalled therapy, the kind that feels comfortable in the moment but produces zero measurable progress over time. We'll walk through therapy that has no real plan or direction, sessions that feel repetitive and stuck in rumination instead of forward movement, and the subtle and not so subtle ways therapy can foster dependence instead of independence, including when identity politics start replacing actual clinical expertise. We'll draw clear lines between therapy that produces real change and therapy that simply feels supportive, between work that builds resilience and work that quietly reinforces avoidance or hands you someone else's worldview. This isn't about attacking therapists. It's about raising the standard and empowering you to recognize when it's time to stop settling for comfortable and start demanding growth. If you've ever sat in a therapist's office thinking, I feel heard, but why am I not getting better? This episode is for you. And if you've been in therapy for months with no tangible shift in your anxiety, your mood, or your relationships, or your ability to function, this one's for you. And if you're wondering whether it's you or the therapy, stick with us, because comfort is not the goal, growth is. Let's dive in. All right, well, welcome everybody. Thanks so much for joining us again. So Emily, it's great to have you back.
Yeah.
I'm excited to continue this conversation. So if you all didn't really listen to the introduction, this is our second installment of a 3-part series where we're really talking to you about what is good therapy or what is bad therapy. And so the first installment, we kind of just talked about what is psychotherapy, where does psychotherapy come from, kind of some real what would you say, guidelines to have effective therapy, to know if you're in good therapy, or I guess looking for good therapy. Both of our practices, Simplify Life Counseling and Coaching and Untangled Mind, we've provided a little worksheet for everybody. So if you have, like, I don't know how to look for a therapist, we have a little guide, questions to provide you. So today what we're talking about is the 3 signs that you're stalled in therapy. So this is going to be a doozy. A lot of you are in therapy and you're probably wondering what's going on. It's funny. I was watching, have you watched The Madison, or no? I told you about the show.
No, I haven't yet.
And they have a scene. Will Arnett is a therapist. And, but anyway, the gal's daughter, Michelle Pfeiffer's daughter in the show, says to him, he's a therapist, but she says to him, why don't you come spend some time with me and I'll tell you about how bad my therapist is. And I laughed out loud because unfortunately, I think, people get together and they hear about, well, your therapist does this, my therapist doesn't do this. And I mean, we hear it a lot. So
that's great.
So we're just going to kind of pop through just some of the data that we touched on first podcast. We really suggest you guys go back and listen to that, but we're going to pop through a couple of those points for you. So 15 to 30% of clients show little to no improvement in therapy. Do you think it's only 15 to 30%?
I mean, I also, like we learn in stats, who are you, who's your sample size? Like, who are you asking? So I think it depends, maybe for that part, but if we were to ask everyone walking out therapy, I think it could be different. I think even probably the specialization differs, right? Like if it's trauma or if it's like a more, like mine OCD, more specialized, I think that's where the efficacy is probably much more different.
Yeah, I would agree. Yeah, if you're going to someone for an actual specialized approach, I think hopefully those numbers are much better, know. But that one's an interesting one because so we talked about this last time, people so often go to therapy like an aesthetic, like it's going to the gym or it's going to get our weekly Botox, or I don't know how often people get Botox, but but it's kind of become this aesthetic thing, and we see it on TV all the time. You and I talk about our different shows that with therapy, and so I think it shifts, and it shifts not necessarily like we talked about last time. It's so important to have goals and have a strategy to where you're going. But again, if it's treated as an aesthetic, one week you might think therapy is effective, the next week you hate your therapist, right? Because there's nowhere they're going. So,
that's good.
It's kind of interesting. 5 to 10% of clients deteriorate during treatment. And we're going to kind of touch on that a little bit today, talking about this idea of deterioration. I'm of the mind that you're going to get worse before better if it is effective therapy.
Yes.
Know? Yes. And so if we see a deterioration, I would say that's, with treatment, like if it's an effective treatment. But what do you think it looks like for people that really truly aren't getting effective therapy? They're seeking care. I mean, deterioration, I would think is even greater, especially for like more like depression, that sort of thing. I would say that number is a little skewed.
Yeah. And you feel so sorry for them because you're like, oh gosh, they were coming in. And then also like, they don't have like a subjective reference for it. So even if they voice to the therapist, I feel like I'm getting worse, or I'm not seeing progress. The therapist could look at that as resistance or, reassurance.
Yeah. Boy, that's a big one that comes up too. And maybe that's part of one of the signs we haven't talked about is people getting labeled as resistant.
Yeah.
And that doesn't help anything.
Totally. And it's, I think in school, not everything has to be pathologized, right? Like it also can be, hey, it's maybe just not a great fit. Like we try to say that at the beginning of intake. That's, just if even for consultations, I'm like, talk to several people for your consultation.
Yes.
You just see that. And just because your friend loved this therapist doesn't mean you're going to,
Exactly. Yep.
And that's totally fine and kosher, and so it's being able to see, and sometimes it's even I've done this myself in therapy of like, okay, this person specializes in this, so I'm going to go to them for this, and then I'm going to a different person. It's not kind of like a Swiss Army knife,
Exactly. Yeah, exactly. It's funny you say that. Like somebody, you might love the therapist, and then somebody goes to him. I had my Dr. Brown in Spokane, Washington. Oh my gosh, just loved her. She taught me so much, and she took me under my wing during my undergrad too, and so taught me just all the ropes. Phenomenal therapist. Had a sleep study clinic, amazing. And I remember I referred a friend. And I was like, she's amazing. I've learned from her. And my friend came back and was like, no. And I was angry because I was like, wait, she's amazing. But, again, that was 25 years ago, a long time ago. But, everybody's taste is different. And so that is it is a very good thing to not necessarily therapist hop, but therapist shop. You have to take advantage of those consultations.
Yeah, absolutely.
Let's see. And then up to 50% overall fail to achieve clinically significant change. Oh, that's awful.
Yeah, it's sad. Oh, we're working on that though, right?
We're trying. We are trying. I'm like, oh, that's kind of embarrassing to read that out loud. So we talked to, there's some hidden problems that no one really talks about. So we've been really pushing this. We do not have a mental health access problem. We do not. We have a therapy effectiveness problem. In fact, Dr. Arthur Brooks, I don't know if you follow him. He's a phenomenal therapist. He said the same thing the other day. He's like, listen, we are doubling down on increasing distress in these clients because it's not effective therapy. It's just rumination.
Yeah.
And it's not an access problem. It really is that we've got to retrain. We've got to figure out something in shifting the idea of what therapy is now. We talked about that last time. What are some other ones do you think are good points for us to hit on?
I think that the percent of clients who don't return to session in our research, it was interesting. Again, who are they pulling? All of that, but we found, about 20 to 57, which is a very big part. I've heard a fourth to a half previously too. Don't return to their first session. I think that is, I've heard that that's because when they've researched it, people feel better talking briefly. But if they could know, hey, it's not just about talking, it's about like, I got that off my chest. But in that first session, you're building rapport, and you're also saying, hey, we're going to work on a treatment plan. This is what I'm thinking, that kind of stuff. And here's, we have assessments and we're going to measure these. I think that all helps with, with the client being able to say, I don't just feel better after the first session, but I'm excited. I know the direction we're going to take. And their buy-in happens, I think, more so the first session versus it being, okay, well, I just shared and now I feel better. I think a lot of clinicians think like, okay, if I go too much in instead of rapport building, they won't come back. And it's like, I think you're giving them more substantial hope.
Yes. Well, because if it's just surface level, what are we giving them?
Right.
And I think, touching on that with the treatment planning is so important, but also something that you mentioned was the readiness. That's something that I think is really important too, with us trying to kind of change this idea of like, what is effective therapy is also not everybody, it's not an aesthetic, not everybody requires therapy. And so, you can't fault all of these numbers on the therapist necessarily. If the client has just been told, well, life is really tough right now, and a friend says, just go get a therapist. When it's just a normal life stressor, it doesn't require this. So maybe they don't show up again because they're like, there's not really anything to change. It's just a release valve. So we really have to assess that readiness to change too. Where are they on the continuum of need? And if it is really just kind of like a life stressor thing, okay, maybe you do offer services, but it's once a month, or it's, they don't need intense therapy, but I think the readiness to change is really incredibly important for us to assess as well.
Yeah, absolutely.
Yeah. Okay. So let's see here. We're just kind of going through some of the things that we talked about. Therapeutic alliance. So that's the rapport building between the therapist and the therapist and the client. It really doesn't guarantee outcomes. You can love your therapist and vice versa, but it doesn't mean that it's going to make a huge difference in what you're seeking changes. That just doesn't work that way. I think we'd all like that, but it just doesn't work that way. Okay, so something that we kind of touched on. Well, first of all, let's just go into number one. There's the first sign of bad therapy or your installed therapy is poor clinical skills. And so we're really harping on this in the sense that this is, again, not us dragging therapists through the mud. That's not what it is. It's kind of pointing fingers at universities. I mean, let's just call it what it is. It's kind of pointing fingers maybe at extended
training.
Like after your master's and doing all that. So it's not just about the therapist. This is a much greater problem than just a clinician. But I think what you talked about, treatment planning, that's huge. We don't see that anymore. Diagnosis and goals. Like, we all had to do that.
Yeah. In grad school, right? Yeah.
We had a whole stinking class on it.
Yeah. Yeah.
Why do you think that that's just thrown to the wayside? Because we're saying, hey, this is a poor clinical skill if you're not doing this anymore.
I have no idea. I was looking up this week, like what's required even before I'm a super CPCS. I forgot what that stands for, but a licensed like supervisor of people who have just graduated or graduated. And they have about 3-ish years of coming through. And so of needing supervision. And it's interesting. I was looking at like what's the standard, and there's not a very clear cut, like this is how you need to write your notes. And this is, and so I don't know, at least in Georgia, we don't have very high standard of what is required. And so I think if that's not required post grad, then people sure as heck probably aren't going to finish it once they're fully licensed. And so I think it's, it comes to us as practice owners of saying, okay, I know that this is the standard, and then this is our standard, right? Like we want you to go above, and we want to be able to have a clear plan, understand, like have, assessments and really like measurement based diagnoses,
So that's a really good, because of your position, and you've had Simplify for 15 years. And so you've grown a business, but you've also brought on brand new clinicians. So, and again, with the hiring and all of that, is it difficult with even the most recent grads, say in like the last 5 years, because there's no motivation to be better, or what is it?
I don't think they know what they don't know. And so like, that's where, and I've heard this is true for other places too, for other fields as well, where it's like, okay, you get your drink out of fire hydrant. And then once you're in private practice, and for us, we specifically focus on anxiety, OCD, panic attacks, that stuff. We'll sometimes see, we'll see depression and co-occurring disorders, but the primary focus is anxiety. And so for us, we know that they come in with a baseline, but we spend about 20 hours of here's this book, here's this resource, here's this, like study this, do this, because we're like, you need to become a subject matter expert. You were familiar, and now you need to become an expert, because this is who we see. And so, I think that they know some, and that's what grad schools do. I think it's like, hey, let's have some in these different areas. What I see a lot of medical students, what I appreciate about it is, they have, they've got residency where they do residency in different sections. But then if you want to specialize, they have fellowships. And I think that for specialists, like for you and for me, we've done our own fellowships in terms of our trainings being very specialized, right? And getting additional credentials. But that was a long answer. Sorry.
No, I think that was great, especially just because, you and I are at a different spot with our businesses. And so for you, I'm really interested to hear how that's played out, because I can imagine that because you are not the norm, you're not, and you have an expectation of a higher caliber and a higher skill level, that I imagine it's very hard. Someone might come in an interview and they're gung-ho, but then they find out your expectation, and then either maybe they say, yeah, I can do it, and then they fall flat. And then as a business owner, you've poured in hours of training and, so it is hard. And I do think, and who knows how they can do this on a university level, but you're right. It's kind of like a fellowship. We've got to shift something. This generalist, we talked about this last time, this generalist approach leads to number one, poor clinical skills. Because when you're a generalist, you don't need a clinical plan. You don't need a diagnosis. You don't need goals. You can just have them sit on your couch, and it's no structure. And I think that's, and gosh, I hate to say this, but it is the path of least resistance. It's the easiest path.
And honestly, like I didn't have what I did when I was a grad. And I think, maybe it's not every practice needs, definitely not every practice needs to be like us. My gosh, there's growth strategies and everything. But like, even if it's, hey, we're going to train in 2 or 3 different areas, because I didn't know what I didn't know. And I didn't know that I wanted to go into full anxiety disorders, until I saw other things. And I was like, gosh, like give me someone who's, I'm not great with grief and depression. I'm just not, I love the energy and the focus and all that kind of stuff, where grief and depression are longer term clients, that's a whole different milieu that you're working with. And so I realized through that process, these are the people that drain me, and these are the people that I want to continue.
Yes. Yeah. Yep.
Well, time stands still, and I could see 10 of these people, So I think there can be some wiggle room, but we still need to give them really great skills so that they can lean in more specifically.
Yeah. And I think I've told you my big fat hairy dream, Untangled Mind Pathway. Part of it is building out almost like a fellowship program for practices, and maybe governments can take it on, and then you get a cut, or there's like some sort of nonprofit scholarship program. But it is really bringing these new grads in and training them every 30 to 45 days in, okay, we're doing children. Okay, we're doing adolescent. Okay, we're doing couples. Okay, we're doing family. Now we're going to try trauma. Now we're going to try depression. And it's a huge amount of work, especially for a practice owner, because then you're going to have to find your own specialist within each area and trust what they're doing.
Yeah.
But we've got to shift it, because you and I found our spark, and we're like, okay, this is the thing I want to focus on. But that's just us. That's not everybody. Not everybody knows.
Right.
And so it's important. So the poor clinical skills, I mean, gosh, the lack of structure, the lack of a treatment plan, it's not all the therapist's fault. It really is not. It's not. And I think too, and I know this is not of your practice, but even when I was doing internships, my gosh, the practice was like, we're going to throw every single, I saw 9 clients a day.
Oh God. 5
days a week. You don't get paid for anything. You don't get a break. You're barely peeing between sessions. You're so and I saw everybody under the sun, which I understand. That's kind of how it is. You have to figure it out.
Yeah.
But the practice owner, and all of the therapists knew this was only about getting as many bodies in through the door. That's all it was about.
Yeah.
And unfortunately, there's those kind of practice owners too that perpetuate this kind of generalist, don't worry about structure approach.
Yeah. They're just in and out.
Yeah. One of the things that I put on our notes, and what Abigail talks about when it comes to this idea of poor clinical skills, there's something called, and I'm so bad at this word, iatrogenesis. Iatrogenesis. I can't say it right. But essentially, it's basically that we can cause harm as therapists. And this is something that Abigail Schreier and everybody, our conversation is kind of us talking about this book, Bad Therapy by Abigail Schreier. It is a hard one to read, but it's good, but it's hard to read. But she talks about that this lack of poor clinical skills can actually harm a client, can actually cause significant risk to the client. So we need to talk about that. I always say to my clients, an informed consent. So that's when we sit down with the clients, their first intake, and we go over all of the spiel, confidentiality, all of the things. I talk to them about this. And I always start with, and I say to them, I obviously believe and love therapy and what I do and what I'm blessed to do with people. Yeah. And I say, but it can cause harm. And they just kind of look at me, and I say, it's kind of like drug commercials where they say may cause diarrhea. Yeah. And they look at me, I said, hopefully I don't cause you diarrhea. So it kind of makes them laugh.
Yeah.
But it's true. We have to, like we said, good therapy, typically you feel worse before better. But if you have poor clinical skills, you can cause grievous harm to clients. And I think that's something that's really important that we should talk about.
Yeah. And within even the families, it's like, we see this a lot, like in this, I think, couples with a cancel culture, this person's unhealthy, so I'm going to have boundaries. And it's like, that's not a boundary, that's a wall, right? I'm like,
yep.
And there's different reasons. People could be causing significant harm. There's, there's reasons for estrangement for sure, but they're also, they can feel very justified and be like, well, my therapist says da 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 da. And then the therapist becomes the subject matter expert on their own life instead of, okay, how can I, create some healthier boundaries? Or maybe I need to put up a wall for a moment, figure out some stuff, do some more healing, and then progressively have that boundary instated, instead of this just like, and you're cut off. And now I feel like this, self-righteous reason that I don't have to talk to you. And it's like, man, that's really hurting family systems.
Yeah, it is. Well, and I think, again, when it comes to the poor clinical skills with this area, and this is kind of important, our point 3 is that when a therapist overly identifies with a personal belief and they project it onto the clientele, that's where the clinician essentially becomes God in the client's life. And they just start making these, slashing out family members. And we don't know the long-term effects of taking that stance.
Right.
Yes, we're experts, but we are not experts in this person's life. We haven't lived it. We don't know. And you have one person's voice on that couch, nobody else.
Yep. Yeah. Absolutely.
And so that can be real dangerous territory. I think too, like when we're talking about, we figured out our niche. I don't do well with depression either. I mean, holy moly. I remember learning this in internship. And actually my very first client in internship actually stayed with me for 3 years, which was fabulous.
Wow.
But severe depression. And and I kept him because it was severe. It was bipolar. We worked on it. And I remember when we finally said goodbye, and he's like, I know, kid, it's been a long time. He's an older gentleman, just loved him. And he's like, I think I taught you a few things. I'm like, yes, you did. You're the last one for me. But he was willing, we obviously extended sessions out. He didn't need me weekly, but I had to tell him, I am out of depth. I'm not sure, but he had a connection with me and was worried about stopping, but boy, I could have caused him such harm, but I constantly talked to him about, like, I'm out of my depth. I need to seek consultation. I don't know what to do with this.
Yeah.
Or EMDR. My gosh, the stories I hear about people just willy-nilly doing EMDR, fishing around in people's heads. It's not good.
Absolutely.
So,
Absolutely. And that makes it stress.
Yeah. So some additional statistics, you got some good ones up there. Goal setting is associated with improved outcomes, higher retention rates. And that's why we're pushing poor clinical skills. It's what we want is the opposite of. So goals, treatment plans, and actual diagnosis. We've talked about measurement-based care. That it really does, it increases about, 20% of treatment outcomes with measurement-based care.
Yep.
It's a big one. It is extra work. We get that, it's extra work, but boy, it makes a difference.
Sure.
What else do you think are some really good things for people to understand? If you're currently in therapy and you're seeing poor clinical skills, this is maybe you're stalled out for a reason.
Yeah. And I think it's also helpful. Some therapists put this on their website, some don't, but just to see, like, is the therapist specifically trained in this area, in this modality, right?
Yes.
So like, if they're doing ERP, if they're doing EMDR, like some, or even for like marriage therapy, Gottman, like, are you level 1? Are you level 2? Are you, it takes, the consumer isn't always informed about this. So I think it's helpful to just empower the consumer and say, like, look up what kind of work they're doing.
Yeah.
And see what kind of training have they had on it, or are they willing to share that? Because you don't want to be someone's guinea pig. You want to make sure that that they've got additional training. I tell all of the counselors in my group, we have to have a set amount, and a set amount of CEU. So like continuous education hours every 2 years. I think it's what, 35,
Yep.
right?
Yep.
And so I'll say, hey, outside of the 5 hours of ethics, for the 30 hours, I want you to go spend this time. Don't just do a free lunch and learn because it's free. Do a specialization. If you can get an additional like certificate, additional credentialing, whatever that is, 30 hours is a lot of
It is a lot. It's
time,
a lot.
right? And so I don't want to just dabble in this because it was free and it worked for your schedule. Like that means, I've gone out to Washington, I've gone out to Arizona, I've gone out to, you too, like different states, spent thousands of dollars on training and have above the 35 hours typically.
Yep.
Right. Because you want to be so well trained in that area. So I think it's really important to ask and to look on their website and see, like, do we have anything else, or is it just baseline there?
And that's, so is it, and maybe that's even a better way for us to phrase that, is maybe it's not poor clinical skills, it's just basic clinical skills, right? Yeah. And I think that's hard too because we want them to see, like, I have really focused my money, my time toward being specialized in this area. But I think too, when it comes to the consumer, when they're looking for us on a website, they're not looking for, is she Gottman level 2? Exactly. Right. And so it's up to the therapist to assure the client, like, I don't just have basic skills. I really have worked very hard to ensure your safety and best care. That's super important for us to say. But having that, and again, to everybody, we're talking about the 3 signs that you're in stalled therapy. And the first one is poor clinical skills or very basic. They got out of grad school and that's like, they do willy-nilly CEs. And half the time, here's the kind of dirty, ugly secret too. Half the time they don't even do the CEs because they don't think the state's going to check. I mean, half the time I hear therapists all the time, they're like, they're not going to check this year, because it's kind of like a lottery system in Georgia, right? And they pull you to see if you do it or not.
I've never heard of people not.
Yeah.
Are you serious?
I hear it all the time because they're like, the state's not going to check. And they just hold their breath. Yeah, I hear it all the time. And I'm like, boy, that's paying Russian roulette. And they'll say it's so expensive. I totally agree. It's insane how much money we have to spend every 2 years just to keep our license going. It's insane. So do I blame therapists that just go willy-nilly, I can get, 5 credits for $50? No, I don't blame them at all. It's expensive. It's very expensive. I mean, like my neuropsych certification, it took, I can't even remember the hours. It was so many hours and a lot of money. It was worth it because I wanted to learn the brain and understand that, but it wasn't cheap, and nor was it fast and easy. So practical questions, everybody, that you can ask yourself or your therapist. We want to give you some application points as we're speaking. So with this first kind of poor clinical skills idea of if you're in stalled therapy, go back into therapy this week, y'all, and ask, what's our working diagnosis? And watch them blanch.
Yes.
If they don't know, what are specific measurable goals for the next 6 to 8 sessions? Honestly, if you see your therapist blanch, or they say, well, what do you think? You're definitely in stalled therapy, because it just says your clinician is either tapped out, they're burned out, they don't have time to think about these things, or it's not important to them. So then it's up to the consumer, like you said, because listen, we are consumable goods. It sounds bad, but we're a service. And if the good that you are paying for isn't able to say, what's this good, what's the service for, if they can't actually articulate that, you need to decide if you want to pay that money anymore.
And it needs to be like when people are like, okay, well, I don't know, I try to bring it up with my clients, but also if they were to bring it up, it's, what do you think? And let's talk through it instead of it just being based on, and that's where the measurements are helpful, right? Of saying, okay, this is where it was before and this is where it is now. This is But I think it's interesting in grad school, so much we're told that we need to, or at least I was told to talk about termination at the intake session, the first session, but then also to wait for the client to want to stop. And I'm like, no, we're, oftentimes I'm not pushing them out, but I'm saying, hey, I think we I try to bring it up earlier so that we can start having that conversation and being like, hey, in a couple weeks, I think that we can go to every other, just kind of let them know, because there is an attachment, there is a bond, and telling them right before isn't helpful. But yeah, we need to bring that up.
Yeah. And I think you're right too. The shift in grad schools has become that empathy only, and they'll determine how things go. And it's like, but wait a second, aren't they coming to us as the expert? Like, why are we letting a non-expert determine what is taking place? That's it's nonsensical. It doesn't make sense.
Yeah. And it's like putting them in a hard place. I've even had psychiatrists clients report back, and they're like, the psychiatrist is like, well, what do you think? Do you want to try a different drug? And they're like, I'm coming to you, like it is, I don't know, it's like that same thing too. It's like, okay.
Yeah, for sure. All right. So let's move on to number 2. You ready for number 2? You want to launch this one off?
So another sign for bad therapy is little to no real progress. So if the sessions feel repetitive, and they feel like it just is rumination.
Yeah. And so let's explain what rumination is. We're not thinking anybody's stupid, but we're trying to make sure that we use our clinical terms. And then sometimes I think we assume people know what we're talking about.
Yeah. I think it's just circling. I say it's like circling over the water, or you're circling, just doing it over and over. We're talking about that thing. We're talking about that thing. We're talking about the thing. We're not going in. And it's not symptom improvement. The conversation feels repetitive. It's all that thing. And it's not revised. We're not moving forward. It's just that that almost becomes, I think, like a label that people can get stuck under. And just, not really skill acquisition in that time. It's just, you're broken. Yep. That's it. And I'm not saying everyone does that, but if you get so focused on it, you're not really using interventions and techniques to get out.
Well, and I think too, with that is like the repetition. I think a lot of times when I see people get stuck in that, so those of you that are in therapy, kind of sit back and think about yourself too, because this is not just about the clinician. But if you are coming in and all you're doing is ruminating or complaining, let's just call it what it is, about someone external to you that you can't change, why are we here? What are we doing? If all we do is focus on the other human, granted, if it's a dangerous situation, something like that, but we cannot affect change on that other human. Their butt is not in this chair with me. So if you're constantly, like when you're talking about on the water, we have a puppy. She's a golden retriever. She's stupid. She turns a year in a couple weeks. She bites her tail. And then she runs around like in a circle, and it's hilarious. But that's what I think we get. We're biting at the tail of that person wronged me. That person did this thing to me. But if all you do is focus on that, and you don't, and the clinician doesn't interrupt and say, stop biting your tail and running in a circle, we have to interrupt this thought pattern, because this is why you're stuck. Because that rumination, it makes it worse. And when we look at the brain, all it does is solidify that same brain pathway. The clinician's job is to interrupt those pathways and to help create new ones. That's what therapy does.
We're supposed to be finding that out, right? Like, this is what's happening. This is what's happening. This is, and if we're not, then it's like, okay, what are we doing?
Yep. And again, you might feel a little bit of relief, doing your weekly complaining session, but you haven't changed anything. And so it really is the clinician's job to step in and say, hold on a second. This is the pattern, this rumination. And clients won't like that. I think that we have softened therapy so much that we're so afraid to hurt someone's feelings.
Yeah. Yes.
But they're coming to therapy to change.
Mm-hmm. Mm-hmm.
We're not chasing the tail. We're not biting our own tail. We can see what you're doing. So you need our voice to come in and say, stop it. Like I use a puppy, stop it.
Right. Right.
Mm-hmm.
Man, it's a journey.
It is. So yeah, so no progress, just repetitive sessions, excessive reassurance. That has become so big. Especially post-COVID. I mean, COVID was awful and broke a lot of people's minds. I mean, it really did. And so I think we went into this very excessive reassurance because it came from a tragedy and a very traumatic event, but we're stuck. We're stuck. We can be loving and compassionate and not reassure you of your faulty behaviors, your maladaptive choices.
Yeah. Yeah.
And then the passive therapist. If you have a therapist that's just sitting there, doing this, nodding their head, we've all been there. I mean, it happens. I had a supervisor once, and she did this. That's all supervision sessions were. And I've never got any feedback.
You just want to like hit yourself? Oh my gosh.
Or her.
Oh my.
Wow. And it was awful because I want to learn. And I'll never forget, the only time she spoke up is when I said, well, I'm using measurement-based care. And she interrupted me, and it was obviously projection, but she goes, well, what's really interesting about this is that I'm in the art of therapy and you're she said, I'm the art of therapy and you're the science. And I just sat there. I'm like, this is the first thing she's ever said to me before, other than just nod her head. And she told me she had the art of therapy down, but she couldn't even supervise a therapist.
Man.
And so I think that's out there. Is that burnout? Is that laziness? Is that, I don't know.
Yeah. Or is that also what they were taught or what they got used to,
Yes.
And so I think the challenge is, remember one of my supervisors in grad school, he was kind of, how professors can be kind of put on a pedestal and stuff. And he had one of his friends had a training center where they had like the double-sided mirrors, and they would watch each other and give feedback. And I'm like, gosh.
I did that in my undergrad. It was awesome.
Well, we do that in undergrad, but he kept doing it. And so he was in his like 50s and 60s saying, we get together and we just pull apart each other's work. And I thought, gosh, what a great, we do that in school. Like I remember doing that in grad school. I think we all do that in grad school, but being able to, but continuing to be like, hey, what do you think? Peer consultation. And we do that in peer consultations. And so I think that's even a helpful thing. Maybe that's something we can add too, is seeing like, are you doing peer consultations? Are you are you asking for feedback? I know that you and I will text each other.
This week I said, Emily, I need consultation. I didn't hesitate. I'm like, I need consultation. We talked through it and you said, okay, but I think you could do X, Y, Z in addition. I'm like, got it.
Yeah.
But but we have to have the humility to say, I need somebody's eyeballs on this.
Yes. Yes. And I think it's also knowing that you're aligned with others. So like when I do consultation, I make sure that it's, someone who I'm asking for feedback because they are in this lane. It's not just a general consultation.
A general consultation doesn't do any good. Any good at all.
No.
So again, back to number 2, y'all, if you're installed therapy, it's because there's no real progress and you're probably talking about the same thing over and over and over again. I had a client tell me, she says she started kind of doing that. She stopped. She goes, I am not weather reporting this week. That's what she calls it. I'm not weather reporting. I am not doing this. But it's great. She had the insight to say, I'm not falling into this. I am not spending my hard-earned money to weather report. I'm not doing it. And that takes courage for a client to say too, if you feel like you're installed therapy, you're allowed to say to therapist, hey therapist, Why aren't we going deeper?
Yeah.
I mean, and that's the thing too. You are still a paid consumer, a paying consumer.
Absolutely.
You are absolutely allowed to say, hey, what are we doing with this? Where are we going? You know, we do it everywhere else.
Yeah.
We send back our meals at the restaurant if it's not up to par. If the dentist drills our tooth wrong, we say, what the hell, man? Like you're allowed to do that. We know that therapy is very unique in the service industry. We understand that, and it's emotionally laden. But as therapists, if it's a good clinician, we can hold space. I know you hate that. We can hold space for your discontent with us.
Yep.
We can't. We're supposed to. It's supposed to be that way.
Yep.
So speak up for sure.
Absolutely. And I will even tell people, like, if it's, even if it's like every 2 weeks or something, I'll say, you know, you can send me a summary and then highlight what you talk through. And they're like, we can do that. And it's like, yes, it is your time. Like we can 100% do this if that's what you want. For sure.
Yeah.
You know,
I'm the same way. I tell my clients, I say, use that portal or however you want, but talk to me, because I might not respond every time, but you bet your butt I'm highlighting stuff.
Yeah.
Like these are the things that we are going to step into, because my job is to look at how your thinking is, what your patterns are, and for me to help you see those.
Yeah.
And so I encourage it too. Bring your stuff in, send me stuff during the week. This is how we give you all the tools. It's more of an intensive, if you think of that, intensive approach.
Yeah.
But it's because we don't want them to become reliant on us. You know,
and like also they might, you know, what we think is important, especially in a narrative, if it's been like 2 weeks or whatever, they might be like, okay, this is happening. We're like, what? And they're like, yeah, but that's all resolved. So I want to talk about this, you know, or whatever. And so I think that, that really helps them feel more in charge. And then also it helps them feel more prepared when we're not there. Right.
Yep. And it's funny, I almost have a hard time getting my clients to engage in that if they've been in therapy for a long time, to go into a more active role where I'm saying, no, I need you to proactively participate with me. And it's so out of the norm of what they've been trained to do in therapy that it's hard.
Totally.
It's hard for them to shift from, wait, you want to talk to me? You want me to engage? I'm like, yes.
Yes.
This is, like you said, this is skill acquisition. And one of those skills is voicing, this is what I need. That's a skill.
Absolutely. And but also how powerful, because they can learn this skill within our office, you know, like if they can't do that there, like what a gift to be able to give it to people.
Absolutely.
You know?
Yeah, absolutely. So additional data that we found here, lack of early progress is one of the strongest predictors of dropout. We talked about that. I mean, so again, if it's just this ruminative therapy and you're just sitting on the couch, not, you know, listening, the therapist is nodding their head, or God forbid falls asleep in the middle of your session. I heard that story the other day. Client went to a new therapist and started her first trauma session, and he fell asleep. And she literally tucked him in, put a blanket on him, and left. I was like, oh my gosh, I'm so sorry. And I said, you really should report this to the state. Like, she goes, yeah. And he still charged me. And I'm like, oh my gosh, no apology, nothing. He just laughed. And she went back because she didn't know what to do. And that
is so
awful.
Tucked him in.
I was like, why'd you tuck him in? I'd kick him. And she's like, I didn't know what to do.
Oh my gosh.
Yeah. And you know, maybe the guy had a really bad night or something, trying to give grace, but
oh my God.
You gotta put your stuff as a clinician. You gotta, you know, like if you're that tired, hey, I gotta get me a cup of coffee. Like, just be honest.
Right.
You know?
It's hilarious.
I know. Awful.
I mean, awful. awful,
but hilarious at the same time. Yeah. So clinical implications, we want to say this: therapy that becomes overly emotionally supportive is not clinically effective. If we keep affirming your emotions, you're going to be in the same mess.
Yeah.
Your emotions, your feelings, number one, are automatic, and they may be valid at the time, but it doesn't mean they're factual.
Right.
And so we want to support you, but this repetitive process is doing you no good. And gosh, you're wasting a lot of money. Listen, all of us work hard for our livings. You're throwing a lot of money away. Like you say, it's a very expensive trash can.
Yes.
Yeah.
Absolutely.
Mm-hmm. Gosh. What else do you think for this kind of, second sign of stalled therapy?
Yeah. I think it was interesting. Yeah. Seeing that the stats and stuff that they had, that there was there for like people, the evidence-based treatment, that they need to see improvement, like you're saying, like 6 to 12 sessions, that they need to be able to see progress.
Yep.
So that they don't drop out, kind of a continuation of that first thing as well. I think, just being able to see what good therapy does, that you're able to like in session hear the updates of, okay, they don't necessarily have to be like, I use this technique and this technique, but you're seeing them, are you using those techniques outside of session?
Yep.
And you're able to get feedback on what you're doing, kind of like a trainer, right? Like, yes, but like, let's lean forward more, use this foot more, like, what are you doing there? And so being able to get some feedback and say, not just like, great, pat on the back, good job, I'm proud of you, but like, hey, what about next time? What if you did, whatever. I think that's really helpful.
Yeah.
Well,
Absolutely. Yeah. And again, we want to leave you with a question that you can ask yourself or ask a therapist. So one of them is, am I learning concrete skills? And if not, what concrete skill would you find most beneficial for me this week? You are allowed to say that. And if your clinician cannot answer, you are stalled out in therapy, and you're not going to get better. They are a very expensive companion.
Yeah.
And expensive companions can be called something else too. So we won't.
What can I be doing? Yeah. Like, what can I be doing? Some people use homework or not homework, but like, what can I do to make progress between sessions?
Yeah. And it can be grounding techniques. It can be doing behavioral experiments, like saying hello to someone if we've got some shy thing going on, or social anxiety. There's so many options for someone to practice tools and flex those new muscles. Totally. I mean, they've got to work those muscles out. So ask your clinician, what's a specific concrete tool that I can use? And if they say, well, you could journal. Okay. About what? So like, I mean, I hear that a lot too. Yeah, they told me to journal a lot. I'm like, what did you journal on? I don't really know how to journal. I'm like, oh, I'm sorry. So number 2 sign that you're in stalled therapy really is this kind of idea of this passive, ruminative, repetitive session. It's weather reporting. You're not learning concrete skills. That's a real sign that you're stuck, that you're really stuck in ineffective therapy.
Yeah.
All right. So this is a big one. This one's kind of a little messy, and leave it to Piper to add a little messiness to it. So another sign number 3 that you might be in stalled out therapy is lack of professionalism that fosters dependence instead of independence. So there's quite a few things that we can jump into. So you can hit those first 3 bullets.
So one is encouragement of dependence rather than autonomy, right? Which is kind of like what we've shared as well, of just, am I making progress? Do you think I'm making progress? No, I feel like I'm making progress. No discussion about treatment timelines or termination. So you've been going to therapy for months on months or years on years, and it's not, you're not seeing like, okay, are we even just okay, we've progressed from this and now we need to talk about this. Some people can be in therapy for years and working through different issues, but it's just like we're the same issue. And then next is, resistance to collaboration or even second opinion. So is the therapist getting offended? Are they, I talk to my friends and their therapists, are they like, no, that's wrong. Are we resistant to any kind of like collaboration on their end? Those are great signs.
Yeah, absolutely. And I think too, when I thought about this sign in particular, I feel like we've just seen, and I've talked to you a lot about this. This is why I went to the state capitol. Mm-hmm. I've seen such a lack of professionalism. It doesn't mean we have to wear suits in the office. That's not what I mean. Professionalism is not what you wear. It's not external. But the lack of professionalism, the inability to have effective conversations amongst clinicians in the field because we don't have the same views, the lack of professionalism, even just lacking clinical skills, that sort of thing. But I think too, what I've seen hugely so is therapists are all of a sudden using sessions to promote more of the identity-based ideas. And I recognize that we all put, like, this is who I serve, this is who I work with. That's a niche. But if you are overly identified with that identity, it becomes mucky. For example, I was watching, have you seen that thing where they bring the podcast where they bring an expert and then they have 20 people with them and they argue against them? Have you seen that?
No.
So the newest one was Jillian Michaels against body positivity movement. So 20 people that were pro body positivity argued against Jillian Michaels, debated with her.
Wow.
Interesting. Now, on its face, body positivity, I can understand, having been previously very obese. I was. However, what Jillian Michaels was saying is that it's grown legs. Like it's not what it was. Here's the thing that stood out to me. And I was at the gym. I shouldn't have been watching it at the gym because I was like scoffing and yelling as I'm watching it. But a few of the women that got on there, well, I'm a therapist. And I was like, okay, they led with I'm a therapist. And then they said, one gal said, well, I'm an eating disorder specialist. She wasn't able to articulate professionally what she does. Yeah. What she did was aligned with the identity politics that was being discussed. So as a professional, she came off so unprofessional.
Yeah.
And that's where my concern is that if your primary lens is only about like social activism, which, listen, I am an activist in my own way too, for better health, mental health standards. You and our faith, you just got back from a huge trip. We do our own.
Yeah.
But if that is our primary lens through which we see all the problems that come in with the client, you are projecting your worldview on that client. Yeah. And that is dangerous.
Yeah. Yeah.
And you're no longer a professional.
Yeah. And you're adding stuff to their narrative, right? Yes. Where it's like, maybe it was, I used to work in a hospital. Like when you work in a hospital, you see everyone is sick. Like you look through that lens, right? Instead of, everyone is oppressed. Everyone is, everyone is traumatized. Everyone is, whatever. And then some of these words are being misused.
Yes.
Right. Instead of them saying, okay, this is like, you are precious and loved.
Yep.
Unrepeatable miracle. That's who you are. Right. And that's it. And then this is something I've gone through versus everyone has this.
Yes.
I don't know. I was in a professional group too, and I was like, oh my gosh, not everyone is this, like I just you mentioned the trip. I just got back from a truly oppressed.
Oh yeah.
Really. Third world country. And so I absolutely believe that there is major oppression and there's bias and there's so much in our country that is not addressed. And yet there's some people who are being using that and putting it onto people where I can come back from that trip and I'm like, I'm not oppressed. Like I'm incredibly privileged. I understand that. And like, that's not the issue I'm going to talk about in therapy.
Yep.
You know?
Yes. Yeah. And that's perfect. And what you speaking to too, that when we have a therapist, if your therapist is overly identifying with oppression, whatever it is, group identity, and again, they're bringing it into session, what they're actually doing is negating personal agency, which is the highest form of mental health. It is. I mean, our mental well-being is that intrinsic worth, that agency, that autonomy. Unfortunately, and I don't think the therapists that do this mean to do this, but you're actually further crippling that human being. You are absolutely saying, yeah, you're broken, but we're going to be in a group and we're all broken together.
Yeah.
And I think that's when I watched this Jillian Michaels thing is that, and there was a couple speakers that I was like, oh my gosh, she articulated her points against Jillian Michaels. Amazing. Good job.
Yes.
But again, if it's this group think and therapist says it has to be this way, they are essentially saying, I require your brokenness to feed my own personal narrative.
Yeah.
I mean, that's hard. That's a hard one to swallow.
And it's a lack of growth on the therapist, right? Of being like, maybe you need to work through that on your end, right? But like, if that's something you're passionate about, then you need to work through that and be able to help people, right? Instead of you're broken or you're marginalized or you're whatever. It's like, yeah, there are definitely people who are marginalized in our society.
Absolutely.
So, we have a huge focus on minority work in our practice because the city of Atlanta is 50% Black, 50% white, essentially. You know, and so being able to have harder conversations for our people of color, you know, with those, we're saying, yes, that is real. Like you are less likely to get a raise. You're less likely, you know, like there are statistics, there are, you know,
absolutely
information. And where can we use evidence-based tools? How can we be able to identify your agency? We're not doing it. We're saying it is there. And how can we also identify your personal behavioral patterns that need to be worked through, that we can change, right? And empower instead of saying, okay, you are stuck because you belong here.
Yeah. And I love how you're saying that it's not an either or, it's an and. You're not saying that you're not confronting this. Last year, you know, we get waves of clients. I don't know if you're like that. Like sometimes it's a whole neighborhood, or sometimes like it's all elderly, or, you know. Last year, I was really blessed, the beginning of last year, that I had so many women from African countries. And I noticed things in their measurement-based care, and I was like, why am I seeing this? They had really, really high task scores. And so, which shows inability to name feelings and describe feelings. And I'm like, I mean, identical, 4 of them in a row. I'm like, what am I seeing? And it was a wonderful opportunity for us to open up a dialogue. I don't know. I'm a white therapist in the United States. I have no freaking clue. But it was a wonderful opportunity, again, for them to discuss cultural norms, expectation of women culturally, what they're up against in families. What was incredible about these women is they were strong enough even to say, I recognize this as a cultural norm, but I need the tools to figure out how to move through this.
Right.
They didn't say, I'm just going to sit here.
Yeah.
It was so cool. And I was literally like, God, why? Like, but it was such a good learning experience. And then they all started, it's so funny. I had 4 women and they all started coming about the same time and they became friends. They just go off and have coffee. They wait for each other after their sessions. It was great.
That's amazing.
And I loved it because I learned so much. And again, it wasn't me negating their lived experience at all. It was me saying, you need to teach me. But they also said, but I need you to teach me too. Like it was a wonderful experience. Experience. So again, counseling field as a whole has increasingly become a mix of identity politics and advocacy. with some therapists hiding behind their credentials while prioritizing their own worldview over individualized, outcome-focused care. We're seeing it more and more. We just are. And listen, advocacy, we are called to that as therapists. We advocate for our clients on a daily. But we have to remember what our primary job is. Give those clients the tools, not help them remain stuck.
And I think that's the most ethical, next point is like the ethical guidelines.
Yes.
Increased client independence as a core goal of therapy, right? And it's ethical to be culturally sensitive, right? And to be informed with that while still helping to make sure that they have increased independence over time,
Yeah, that's exactly it. Longer term therapy, measurable goals is longer term therapy without measurable goals is correlated with poor outcomes. We're talking about that. So again, the fostering dependence, And again, when we see that fostering a dependence, it could be that we just really love our clients. That's hard. It's hard to say goodbye to clients.
I don't like our clients.
No, it's hard to say goodbye to them. It's really freaking hard. But we can't let that get in the way of their independence. We see that a lot. So clients who perceive therapy as indefinite are more likely to disengage or plateau. So again, fostering dependence or not having, that professionalism, you're going to see this happen more and more.
And that happens with a lack of progress, right? And unclear direction. That's leading reasons for termination. So like if they think it's going to be long term, like that goes, what you just said also goes in line with, they're like, okay, is this indefinite? Have we seen progress? Where are we going? And they're more likely to trend off or fade out and stuff. And that also adds this like financial burden because, you want to get a really good, we call it like ROTI, like return on your time investment, right? So we need to be able to say, hey, if I bring my car to the mechanic, they're going to get a service. It's going to get done. Something's going to get oil, tires, something like that is going to be fixed. And then I come back and I'm like, thank you, I can see it. But when people don't see that and they're like, okay, I'm having to, whether it's insurance or not, whether it's convenient or not, like it's still that financial burden.
Yeah, absolutely. And that financial burden is huge, especially, and I'm sure you've heard the stories too, when people come in and they're heartbroken because they're like, I spent so much money and I don't know what I learned. Right. And all of us, again, we all have to pay our bills. We can understand that, so, so this is interesting. Abigail Schreier calls what we're kind of discussing, this dependent, therapy. She calls it annuity therapy. And so profitable for the therapist, but it can quietly train people to believe they can't handle life without weekly guidance.
I loved that phrase.
Annuity. I was like,
oh man, our clients are not part of our portfolio, right? Yet it can very much be that. And where it's, even when I'm supervising people and talking with them, they're like, oh, I'm bummed because I really liked this client and they're leaving. And now, but hopefully as clinicians, we're being good business people too, or we're super, we're marketing and we're going out there. And so it's not based like us getting, you shouldn't feel like your therapist is dependent on you. That's not, if we're not, if it's low, if it's, whatever, like that's on us to figure out if we change, but your therapist you shouldn't be needed,
Well, and even if it's not, financially based, gosh, I mean, if you do not do your work before getting into this field, then you're going to be desperate for the people on the couch to feed you, which is also a very dangerous place to be in. And so that might be another sign for y'all listening. If your therapist is talking to you about their life problems and it's not relative to what you're talking about. I share with some of my clients, like, oh man, like clients my age, this perimenopause can just jump out the window, But if the therapist is solely talking about what's going on with them, they're fostering dependence on you because they require you to care for them.
That's not okay. Not okay.
That's completely backwards.
Yeah. Yeah.
So a practical question to ask: if you're not seeing clear, measurable progress in the next 6 to 8 weeks, would you support, say this to your clinician, would you support a consultation with another clinician or a referral? No matter what, they're probably going to take offense. I mean, let's just, right? Nobody likes to hear this. But if they are a professional and they truly are wanting to instill autonomy and empowerment in you, they'll process, ouch, that hurt, I don't appreciate that, and say, sure. So anticipate a little bit of pushback. But if they're a true professional and they truly are in it to help you, they'll say, sure, I can help you with that.
And hopefully they'll say, tell me, instead of, wow, that shows, hopefully they're not going to pathologize what you're saying and not say like, well, this is your perfectionism or this is your life or whatever. They could say, okay, so it sounds like you're not feeling satisfied in this process. How can we make this work so that, that you brought this question up, how can I honor that?
Yeah.
And how can you feel satisfied today? And how can you see these measurable outcomes? But if they turn it and make it more about you as the client being, it's being something about your issues or your trauma or whatever, we need to kind of red flag.
Yeah, big red flag. Yeah. And again, that's a good point too. We provide feedback all the time to our clients, but we need it too. I mean, for us to just because we got our niche down doesn't mean we know everything.
Totally.
We require your feedback. I tell my clients all the time, I said, my husband says I'm as subtle as a car bomb.
Yeah.
And I say, you have to give me feedback. If that was too blunt, you need to say, Piper, too blunt. I need that too.
Yeah.
I'm a human being and I need to hear feedback. Or like when I did revisions on my workbooks, I got feedback. And there was one section that everybody was like, that is the dumbest thing. I'm not doing it. But I needed the feedback. I had, and did it hurt a little bit, but I was like, okay, it was kind of dumb.
Absolutely.
But we need that feedback from you as well. So even if, as you listen, you're like, oh my gosh, I'm in stalled therapy. Don't automatically assume that you have a bad clinician. Maybe the clinician just doesn't know how to enter into asking for appropriate feedback, or maybe they're afraid of hurting your feelings and they're just really tender-hearted. That's okay. So if you feel like you're stalled and these 3 signs are really standing out to you, start the conversation. Therapy is conversation. And a good clinician is going to say, welcome that conversation and say, help me learn more.
And they might not know that you feel stalled. That's the thing, right? Like therapist, I don't know about, I'm sure you've had this, but going to dinner parties and someone can be like, are you reading my mind? I'm like, I'm a therapist. I'm not psychic, and I don't believe psychic people can read minds, but just, I think with that of, your therapist is good, but they're not God. And
exactly.
Your therapist, can work with only what you've given them in terms of like what you disclosed and what you haven't. And so it's important for you to be like, hey, I'm kind of feeling like we're, bring that up, because the therapist can't know what they don't know. And so you giving them that information is a gift, and it will be more rewarding for you, and it'll be more effective overall.
Yeah. Yeah. And again, what Emily and I have said through this whole series is this is not about raking clinicians through the coals. It's not. It is about giving you, the consumer, awareness, but also saying to clinicians, hey, we got to step into some tough things and recognize some tough things. Do we want to elevate ourselves in the industry, or do we want to continue the norm? And I think really the majority of us are saying, no, I really love what I do, and I want to affect change, not just in people's lives, but in the industry. So again, this is not us trying to attack. It's just saying, hey, we gotta take a hard look. And I think, like Emily was saying, to have that conversation with the clinician is truly a gift. When I get feedback, hard feedback from clients, it really is a gift. I don't like it. Nobody likes negative feedback. But it's so helpful for our growth. We need it.
And as therapists, I would say we'd rather have our clients say, hey, that was too direct, or hey, I'm not ready to go there yet. in efforts to say, okay, otherwise we're continuing to do the thing is not helpful for you. And the very place you're supposed to get healing and tools is actually not feeling safe. You know, if there's any place that you feel like you can give that feedback, it must be the therapy office. And you can say, hey, you're my therapist. You know, this is gonna be hard for me to say, and da 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 da, you know, but just say it, right? You know, like we prefer in session. I've gotten it where it's like an email, like, hey, I realized this afterwards. I'm like, good for you. Let's talk about it next time. But like, also good for you. You said it, or you wrote it, or something. You know.
And again, it's the practice of those skills, and a clinician that really is truly there for your growth will absolutely say, this is great. I'm proud of you for practicing this skill. I know this was hard, and I hear you. And let's talk through this. How can I shift things for our work together? So I think that's a really wonderful point. It's funny. I think, like you said, people think we can read their minds and that we know everything. And I know for me, and I'm sure you'll say the same thing, I learn from my clients
so much
daily.
Yes.
You know, or I'll say something to them. I'm like, oh, like it's for me. I'm like, what am I talking about? I'm a hypocrite.
Yes.
You know, but we learn so much in this process. Like, we're not God. You know, we study this and we love the work that we do. But it really is a 2-person job.
Totally.
It's a 2-person job,
totally.
You know. So, well, this has been a fun conversation. Hopefully y'all are kind of following along and understanding where Emily and I's hearts are in this process. So these are the 3 signs that you are in stalled therapy. So just to kind of wrap those up, number 1 is poor clinical skills. We're talking about a lack of diagnosis or goals, no treatment plans, no defined outcomes, that sort of thing. Number 2 is there's no progress. Repetitive sessions, weather reporting, rumination. You're my golden retriever biting your tail and running around the room and nobody's telling you to stop. And then number 3, the lack of professionalism and that increased fostering of dependence rather than your independence. Those are some pretty significant signs that you are absolutely stuck in some stalled therapy. But hopefully we've given you some, practical questions that you can ask your therapist. Be bold, y'all. You're paying for something and we need to learn from you. So be bold. We need to hear from you. Anything you think that would be helpful for us to close up with?
I think that's it. I think just encouraging both sides. We want this to be encouragement, for counselors and for the clients, like we want to help raise the standard. And we want to be able to be better so we can do better, that's programmer. But just so this is all to help. And so we hope you guys can lean into that. It's uncomfortable to lean into it and see where the progress goes.
Yeah. Well, our 3rd installment is probably going to be a lot of fun because we are going to speak to those of you that think that what we do is a bunch of hooey, a bunch of BS. And listen, this will be probably a bit of a parody. There's a gal that does these parodies on Instagram. She cracks me up, like the old therapist, and she does these parodies and stuff. So she's hilarious. I'll send it to you. But we're going to speak to those of you that really think that therapy is bunk, and we get it. We've talked about the reasons why you might think that, but there's also some real misunderstood things out there as well. Everybody thinks that you lay on a couch. That's not what you do half the time, so we're going to talk to those of you that think that this is a bunch of BS, and we'll have fun with the 3rd one. Not going to be so heavy, but we'll bring in all of those false ideas of what this is and hopefully put your hearts at ease. So thank you everybody so much for joining Emily and I. Please be sure to reach out to Emily at Simplify Life Counseling and Coaching. And you can, find her services there. She's got a great staff. Again, she follows measurement-based care, outcomes, treatment planning. That's why she and I talk. So be sure to reach out to her and get to know her for any of those anxiety needs. And we just really appreciate everybody tuning in. We'll see you next time.
Yep. Thanks.
Bye. Take care, everybody. That brings us to the end of this episode. Thanks for joining me. I hope you learned some tools that can equip you to untangle your mind and untangle your life. If you're curious about working with me for your anxiety or trauma, head on over to my website at untangledmind.net to connect with me. If you enjoyed the show, please rate and review me on your podcast listening platform and share it with your friends and family. As always, thanks so much for listening to me, Piper Harris, with the Untangled Mind podcast. I'll talk with you next time.